mailing list is just sending your email to vindaba@globalhealth.rutgers.edu. Please ensure that your mics are muted throughout the presentation. Only after the presentation will you then be allowed to comment or ask any questions. The sessions are recorded. If you want to go back and listen to the presentations, you have the opportunity of doing that by going on to the YouTube page where the webinars are put up. So that's the YouTube page, the Botswana-Rutgers Partnership for Health YouTube page, which has all the webinars, all the previous webinars, including this one that will also be added onto that page as well. There is the COVID-19 government portal, which includes all the guidelines on COVID-19. So you can go onto that URL and you'll be able to access all the guidelines that have currently been developed on COVID-19. There is about 20 to 22 guidelines on there. So if you just go there, you'll be able to access those. So today we have a presentation, but it's also a discussion by a team from the Ministry of Health and Wellness. So the topic for today's webinar really is the primary healthcare approach to home isolation for COVID-19, strengthening home management of COVID-19 patients. And the reason why I'm saying it's also a discussion is the team would really appreciate to hear your opinions and inputs on how this can be improved or how this can be applied to COVID-19. So the presentation will be done by Dr. Malebogo Kebabonye, who is a public health specialist, who is currently a consultant for primary health care at the Ministry of Health and Wellness. So Dr. Kebabonye will take us through her presentation, after which we will then comment and ask her questions, as well as contributing to how we can improve this approach. Dr. Kebabonye.
Good afternoon. Thank you very much, moderator. Let me greet all the participants in this webinar, and thank you for inviting us. With me, I'm presenting a joint work. Have Dr. Honzitsimoho with myself, and I'm with Robert Momagwa, who is also supporting on this model. So we are presenting as part of a consultation. We are expecting that participants in this webinars are from various platforms, that is both public and private. So this will be part of the sensitization and consultative webinar to inform the healthcare workers on the proposed model that is part of continuity of care. This is using the primary health care approach to implement the home isolation for COVID-19 as part of the strengthening of the case management. Oh, next slide, please. Sorry. On a background, and I think this is no news to all of us, we are aware that Botswana has experienced 3 waves, and currently we are in the middle of a 3rd wave surge. And with this, we have seen quite an increase in the number of new cases for COVID-19 and the mortality associated with it. Also, what we have known, or what has translated, is that over this months, we have seen more and more people needing home care or being at home, even though they are COVID-19. We are also very much aware that these active cases that are at home were inadequately monitored, and there has been quite a varying approach in how these patients have been managed in the homes. Next slide. Next slide. Who's changing my slide? Okay, so back. So we are here presenting a model that has been proposed, and the objective or the main aim of this approach is that we reduce the COVID-19 related morbidity and mortality through strengthening home care. And at the same time, or the critical objectives around this will be to ensure that we strengthen the clinical care for COVID-19 patients who are managed at home, and we do early case findings within the household as part of mitigating against household becoming the super spreaders. We also hope to, through this model, standardize the district COVID-19 home monitoring approach, and to strengthen the IPC practices at community level, that is from household to the community, and revitalize the community participation within the response. Next. This model is anchored within the overall guiding principle for primary health care, being that universal access and coverage to ensure that people or clients, we reduce the anxiety of the clients in knowing where to get the care that they require. And secondly is to also put the community and individual at the center of their care and improve their involvement and self-reliance. We also, through this model, part of the guiding principle is to ensure that we have an intersectoral action for health and utilize that appropriate technology and be cost effective in implementing healthcare services. The model that we are proposing as part of the standardized will follow a 3-tier approach, with one leg that is focusing on case management, while the next leg is on capacitating the household and the individual through health education and promotion and infection prevention and control. And the next leg will be part of the psychosocial support, and this will be offered in an integrated phase, in that we expect that in this model, we will have a one encounter with the client that will lead to identifying the needs of that client beyond just COVID-19. Next. So these are the components of this care model and how each component is being proposed. So under the case management, we will have the positive clients being consulted and admitted to care, and this will be done both physically and remotely. We have clients' disease will be graded or categorized as per the national guideline, and appropriate care will be initiated based on that category, and household surveillance will be done as part of the case management and surveillance. Within the IPC, health education and IPC, we expect that we will conduct household risk assessment, conduct client and household health education and promotion, so that they are aware of what to do and what not to do, and improve the overall or give education that caters for any other beyond just COVID-19, as I have said, identify and revive community support structures within the locality for continuity and cohesion, and refer clients appropriately. And under the psychosocial support, and this will be done collaboratively with the Ministry of Local Government, we will conduct the household welfare assessment and avail and supply the household packages as per the guidelines where possible, and avail mental health support to the clients and the caregivers. Next slide. So this model is not new to the Ministry of Health nor the districts, as it benchmarks from the approach that was used before with the community home-based care program. So through that model, and as per the guideline for the integrated healthcare services, community healthcare services, we identify the community health health workers as the entry point into care at community level. These community health care workers usually are at district level. They are led by the HERE or the health education assistant, and both the community health care worker and the volunteer, they will use simplified tools to identify the household affected and conduct initial assessment to address both medical and psychosocial need. The team will refer appropriately to the next level, which is the nursing care. And this nursing care will be done within the locality. That will be either the clinic that is supporting that local ward or the village. So the nursing care will be able to conduct the evaluation as referred by the community team and immediately start the needed treatment for the patient. The nursing care will also be expected to supervise would be the immediate supervisor for the community and the technical team. That is both the health education officers, the IPC, and the psychosocial support, and to manage the help desk. The nursing care will be the one to then, based on the category of the client as assessed, will refer to the next tier, which is the medical care. And the medical care will either be to facilitate the immediate evacuation or to manage the patient who can be managed at home. We expect that through this model, some clients, or we should be able to do the oxygen management at community level. And so at community level through the oxygen compressors. Next. So this is how we envision the model to work. As I have already mentioned that in this model, we are bringing in the telephonic consultation. So to minimize contact for both the client and the caregiver, we will, from the time of testing or from the diagnostic census, we expect that clients will be linked to care, and triage will happen at the level of the diagnostic center or the linked services. That is either the DHMT or the local clinic or the cluster clinic. So this links, that is the local clinic or the cluster clinic, should be able to contact the client, or at the same time, a client can self-report or can trigger the response or the registration into the model. From the telephonic contact, as I have said, at that level, we expect basic triaging to be done, which will then position or give an idea as to the next care that will be delivered to that client. We then from there expect targeted home visit, and through this targeted home visit, that will be determined by the frequency and the conclusion that was drawn on the initial triaging of this client. This visitation can either be done by the community health worker or the nursing care. And that will be based on the risk assessment. And this will trigger on up until where they will have to have either an ambulance evacuation. On the cutting through will be the revitalization of community structures. And this revitalization of community structures is to ensure that we build support services or support centers within the community that will continually work on risk mitigations that are peculiar to that certain community and support the household, because with COVID-19, what we have seen is that many families have felt unsupported through the quarantine and the isolation phase. So we will be reactivating and revitalizing these support structures that have been there, such as VDC, VHCs, and the other NGOs, which can work within the community to ensure that we support the community members beyond just the healthcare delivery. Next. We are currently continuing our engagement with various sectors, and this engagement is to ensure that this model is coordinated very well. At the national level, the coordination is led by the Ministry of Health and Wellness, but we are working together with the Ministry of Local Government. We have already engaged the district level through the rightful structures, and we continue to engage both the partners, the implementing partners and strategic partners and the private sector to ensure that there is a buy-in into the model, and we are able to recognize where we can add in to ensure that this model works. Next. We have identified a set of resources or skills that are required, and this is the example that we've given here is such a model working from a local structure, that is from a village level to a higher level. And in order to build continuity, because we expect that this model, once working and working very well, it should be able to deliver beyond COVID-19 pandemic. So what we have put in place is to ensure that the leadership and coordination at community level is put in place, and we have repositioned them, and we continue to capacitate the KOSI, the VDC, and the volunteers and the village extension teams to ensure that there is equal or collaborative participation for this model. In the technical support, we have identified the environmental health officers, because we know that with this pandemic, there's so much waste management, or we need to do proper waste management at community level. So we have identified the environmental health officers, or the infection prevention and control officers, health education officers, social workers, and district development officers who are there in order to give support beyond that of medical care. The medical team we've put there in at minimal those that are needed in order to have this model function very well. That is the healthcare auxiliary, the nurse, and the medical officer. And the other resources there is just as to the basic package of what will be required in order to reach the needed client in a timely manner to deliver the needed care. Next. So in here, we have just used the Chobe Regional Health Management Team model as a way of showing how some of the districts have localized this concept. And this is an example borrowed from Chobe that have since put their district into 3 core centers, and these core centers, they have been divided into Chobe West, Chobe Central, and Chobe East. As I have said before, that the guiding principle is to remove the anxiety within the community members and ensure that communities have a sense of access to care, and that access to care means that we have these numbers that are communicated, and clients know which number to dial in order to trigger the appropriate response. So this is just to give you an example, and we, as we continue, we expect that more and more districts will be giving a guidance as to how clients can trigger care within that model. And I think this is just lastly as to what we will be looking for in order to monitor the progress into the model. As I have said, we are currently sensitizing and consulting with our stakeholders, and we expect to hear more from you. But at the moment, what we, as part of monitoring, we will monitor this model from the point of the help desk, that is to monitor the number of clients that or calls that are received per day, and the numbers of clients that will be registering into the program. And this will actually be looking at both the client initiated and the district initiated or caregiver initiated. We'll also look at the outcome, and the outcome is that we expect that these clients, as they registered, they need to be seen. So we'll be looking at the proportion of clients that were contacted for assessment, to look at the status of the client within the locality, and this will be to look at the burden to know that what kind of clients are being put at home, and if the district is managing the proportion of clients needing daily medical care, and the community COVID-19 mortality, that is the BIDs, and this will show if this home model is working or not working, or if the district is managing or not managing. We'll also look at the household assessment or surveillance, and this is the number of cases that will be identified through the active case finding in the household, the proportion of client or household that are referred for psychosocial support, and the number of households that will receive the psychosocial support. This element here is very important to us because anecdotally, we know that the reason patients or clients do not adhere to the COVID-19 protocols is because of the lack of the psychosocial support. So we'll be working with the local government to ensure that families are assisted very well and are assisted appropriately in terms of the psychosocial. Then the revitalization of community structures. This is to ensure that this model becomes sustainable at community level. So we'll be looking at the volunteers that the community is able to recruit into the program, and the activities that these communities will be doing independently in order to minimize the risk of spread of COVID-19. This last slide is just to appreciate what we already know is happening. And this is one package that we know is out there and is being done by the private providers sponsored by BOMAID. And you would also realize that within this package, I think for this one, you realize that it's mainly on medical care management, but we would like to see a similar approach, but with some kind of linkages or synergies such that ultimately clients are able to receive a holistic package that attends to not only their medical need, but also to other needs and to integrate them effectively within the community. So some of these are the things that we are looking into and looking on how to work with these partners to improve such models more. I think this is the last slide. So we will be waiting for your comments and answers. Thank you very much.
Thank you very much, Dr. Kebabonye and team. I think from my side, I think we've been really lacking a sense of ownership and from the community. So I think this approach will really help in giving them that sense of ownership in the COVID-19 pandemic. So participants, I'll now open the floor for any comments, any questions, any additions that you would have for the team. Any inputs that you'd like to make on the approach that the ministry will be taking? Okay, Dr. Nkomo, I see your hand up. You may go ahead.
Thank you very much. Thank you, Dr. Kebabonye, for the presentation. Sorry, I think I joined a bit late, but there was a diagram that was quite interesting to me. The diagram that had community health worker, nursing, and medical. So I did not understand that diagram because maybe I did not understand the flow. So if I'm a COVID patient in the community, most of the times I remain in the community. And if I complicate, it's usually that I go to the hospital. So, sorry. Oh, sorry. So I did not understand the community nursing and medical. Maybe it's because I did not understand what was flowing as I joined the meeting late. Because what you're saying is, I'm sick, I'm in the community. From there, if I'm complicated, I'm in the hospital. So where does the nursing, the medical, and I'm sure if I'm in the community, I'm treated by a doctor somewhere. Thank you. Maybe I did not understand.
Okay, Dr. Nkomo, thank you.
Sorry about
Dr. Kebabonye, I think he just needs a clarification on the just a quick recap of the approach and how the nurses are involved.
Thank you very much. In this here, Dr. Nkomo, thank you, Dr. Nkomo, for the question or the comment. What we were trying to show here is the way the referral will work at community level. As I was saying, the community health worker is the entry point for identifying the client, or they are the immediate link of care with the client. That which can be done by the community health workers, that is your basics, the community health workers will be able to do. And where they cannot do, or what they cannot do, they will refer to the nursing care. At community level, much of the time, the nursing care is usually the lead or the cornerstone for the client management, and what the nurses cannot do, they will refer appropriately to the medical team. This we also had in mind of saying, will it delay care of client? But we through the flowchart for case management, the nursing care will be given the guidance as to when to trigger an immediate evacuation of patient. Here we are assuming a client that can still be managed at community level, and the nurse needing a medical assistant or the doctor to help them in managing such a client. Thank you.
Thank you very much, Doc. Dr. Nkomo, are you clear now?
No, that's fine. Thank you.
Thank you. Any other questions or comments? Dr. Lebilonyani, you may go ahead.
Thank you very much, and thank you, Dr. Kebabonye. I think we are going back to what really in public health, that you are taking the treatment closer to the people, because this is the public health intervention. So my question is, as your entry, I realized that you have the hears, the nurses, and the medical doctors. I think I'm going back to the same diagram. Have you assessed, do we have adequate hears at the district level? Is the training still, or that we have at least adequate, or are we going to recruit more? And by doing so, if they're going to do now the home care, in many facilities, clinics, there's already without COVID, already existing shortage of staffs, and they are the ones who are assisting, especially in the child welfare. Other services, how are we going to cover them? And secondly, the 24-hour, the telephone, the mobile number, is it working? Is going to work 24 hours? Are they dedicated people who will be answering this call, because the assistant might be needed anytime? What is the plan? Thank you.
Thank you. Team. Dr. Kebabonye, Mr. Mumakwa. Hello.
Thank you very much. Sorry. Thank you very much, Dr. Lebilonyana, for the questions. And thank you for appreciating that we are talking about a healthcare service that is already overstretched. But nonetheless, we cannot pretend that we do not know that patients continue to be at home. And this is why we think with such a model and done and delivered very well, it should relieve the anxiety of both the client and the caregiver, because we will be able to at least categorize the patient and reassure them to continue staying at home. We expect that the helplines will be 24 hours. And at the same time, I know you asked about hiring. Will we be able to hire? The reason we are sensitizing about this model is because we are continuing to seek partnership with some of our private partners that we can work on this model together. And in so doing, it means it will take away the pressure from government, because currently much of the care for COVID-19 has been provided by government. I was bringing in the model as provided by, or that is being done by BOMID, to show that it is something we are offering a similar package that now brings in a lot of choice to the community members. So we hope that that will ease off in government being the main lead, but we'll continue to recruit, and we continue to rely on some partners. Some have come through and we are in negotiations with them as to how they will help us. And we are also going to be looking on the volunteers. Dr. Lebelonyana will know that our community home-based care, even at the height of HIV/AIDS, was pretty much dependent on the volunteers who helped so much on the delivery of services to the community. So for now, we will be looking and working within years an already overstretched community, and hoping that as we go on, we should be able to see a buy-in of the community, behavioral change, and as we see behavioral change and we restore the trust of the community on the healthcare system, we should see the ease off from the healthcare system. Thank you.
Thank you, Doc. I see 2 hands up, so I think I'll let them go ahead and then you'll answer to the questions after that. Bukwena Mwali, you may go ahead and ask your question. Then after that, Dr. Mukadi, you may go ahead and ask yours. Thank you.
Okay, thank you, Chairperson, and thank you, Dr. Kebabonye, for the presentation, and thank you all for the discussions. But I think this model is not very far from what we have been doing all along. It's just that we didn't have the element of a hair in it. The nurse was the first point of contact, because the patients are usually diagnosed by the nurse, or where the nurse is available, and the nurse is the one that would take on the responsibility for enrolling the patient into a home isolation and counseling them, and then the follow-up. And then we have these patients enrolled and linked to a facility that has a mobile phone that they're given the number and they're able to call at any time. We would see how we can infuse the hairs in it, but the challenge is going to be what has been highlighted by Dr. Lebelon, that they are already engulfed in other activities that they are doing, child welfare, all other things that they're doing, malaria and all others. So we have been working pretty much well without the hair, but the nurses and the doctors have been assisting in home care of COVID-19 patients very well. What I also want to ask from the audience is that I do understand that one of the objectives of this is to decrease mortality due to COVID-19 in the community. But from our statistics here, majority of our BID, if not all of them, we didn't know they had COVID. They were not diagnosed with COVID prior to their deaths. They were only swabbed as BIDs, and then we find out that they had COVID. So I don't know if they were patients in other districts where the patients were known COVID patients. There was some failure in managing them at home, and then they succumbed to the disease. I don't know about that one, but in our districts, the patients were not diagnosed prior to their death for us to have intervened in between. So that is the discussions, that is the questions that I wanted to hear from the audience as well, to see if there are some gaps that were, or there is a real gap that is going to be addressed by this model in terms of reducing mortality due to COVID at home. Thank you.
Thank you, Dr. Mwali. Dr. Mukadi, you may go ahead.
Okay, thank you very much, Chair. Thanks to Dr. Kebabonye for the nice presentation. Let me congratulate you and appreciate once again for this model, which to us is going to reduce the mortality and morbidity due to COVID. Before I can go to my question, I'll maybe try to answer Dr. Mwale, as you want experience from other districts, if among the BRD, they were positive, I mean, they were the COVID positive patient. Yes, like our cases in Chobe, after analyzing our data of the mortality, we found that some of the clients were dying from day one of diagnosis, and some of them, they were dying from home after being diagnosed, they just brought in dead already. Then we thought those who are being brought already dead, it means there was poor monitoring of those clients while they are home. And the moment this model came up, we thought this is the right time to answer the question we had of those people who were dying shortly. We think those who are dying, who are diagnosed maybe after, it means people are taking time to come to the facility. It means we have to work somewhere in the community on health promotion, educating our community to seek medical advice, medical attention on time. And those who are sick home, as you may be aware that COVID mostly is a silent killer. Hypoxia in COVID is silent. So someone may be having saturation of 80 still home asymptomatic. And the moment he starts symptoms, it means this person is already around 70 or 60. So with this model, we think that we will be monitoring our patient for the first 3 days of diagnosis. We may pick this hypoxia on time and put them on treatment. So when it comes to the nurses, overloading the nurses of everything, the model actually, as we know, for the home-based care, as we've been doing it before. So the nurse is not going in the community every day. We have the community health workers, volunteers, and the healers. So with a simple model of the tool, we develop a simple tool which they may understand, they will be reporting this to the nurses in the clinic as we've been home-based care, and from there the action will be taken. Because if the simple tool, as we are saying, the oxygen, I mean, checking oxygen saturation, with a short training, these volunteers can check the saturation, and once it is low, or blood sugar, if they have a healthcare assistant, they can pick this and inform the nurse, and nurse from there can make a proper diagnosis. That's what I have to try to comment on Dr. Mwale's comment. So coming to my question is from the indicators. I would like to know how often do we think we will be reporting this home isolation, this model? Is it going to be daily like we are doing for COVID today, or weekly or monthly? But if I have to opt maybe for weekly, which is maybe easy to do, to be reporting weekly. Now within the indicators, I don't know if you can maybe put back the slide where the indicators were. Okay, I can't see it is not coming anyway, but I'll try to say something. So I feel, I don't know, is it not possible in I mean, among the indicators, what about inserting also the active cases? Because in a facility or in a village, if they have to do home visit, at least if this report is giving us the number of those clients who are active by that moment, it will help us to take also action. Let's say if for the past week we had maybe 20 cases in that community active cases. And suddenly after a week, we have 200. This indicator will tell us there is something going in that community. We have to go back and maybe act. Another indicator I would like to mention is age. So if the age can come up also, we know, Les were saying about 55 years, 55 years are at the risk. But having such number, how many people are 70 years in that community for that week? If there are maybe 50 patients and all of them around 70 years, it will pick us, it will be something which is going to alert us, no, there is something going wrong on that, in that catchment area. So I think the age also can be part of the indicators and the active cases. Just my thinking. Thank you.
Okay, thank you, Dr. Mukadi. There's already an indicator for the number of cases identified through active case finding. Are you talking about something different from that?
Yes, case finding is active case finding is where you are going to do the cases. Let's say we go in a household, you have one positive case, and you find with the other household members, they have not been tested. So you may test them and to come up with 5 or any number. So these are active case finding. But the active cases is those who are actually positive in that community.
Okay, you are referring to the total
Yes,
cases,
madam.
active cases.
Yes.
Okay, thank you so
Yes,
much.
ma'am.
Okay, thank you for sharing your experiences, as well as Dr. Mwali. Thank you for sharing experiences from your DHMTs. I think really your experiences emphasize the need for involving the community in the management of COVID-19 at home. Dr. Kebabonye, I'll allow you to respond to some of the questions that they brought up.
Thank you very much. I don't think I had, but I would like to thank the comments made by Dr. Mukandi, and even to thank the comments made by Dr. Mwali. As one of the things, like we're saying, we are not reinventing the wheel, but we are building on what already has been happening at district level. And in building what is happening at district level, we also appreciate that various districts will be at various level of implementation, and they may have a way to which they would want to localize this model. So this is just the guideline that can be adapted to anyhow how people are going would want to adopt it. I think I'm seeing here from here, what are the next steps? And this is a question that is coming from Dr. Lebelonyana. What we expect from here, Dr. Lebelonyana, as I've said, we have already exhausted much of the consultations in getting people on board with the proposed model and availing the resources that are needed. We will be going into a refresher training of the healthcare workers with the DHMTs. And once the refresher trainings have been done, we will then start, one of the things that we'll be making public will be the access, the numbers that the community can call in order to trigger the rightful response. But like I was saying, and I think I'll have to repeat this over and over, we are literally rearranging furniture on an already finished house. We already have clients and patients at home, but we are mainly just working to improve as to how they have been kept at home.
Okay, thank you very much, Ngaka. Dr. Mukadi was asking how often will these indicators be reported from the districts? He was also suggesting an addition of another indicator, which will indicate the number of cases over 55 years. So maybe you
Thank-
can just allude to those.
Yes, I think I forgot to say, in terms of how often these will be reportable, we are working with the M&E team to see how, without putting burden to you, Dr. Mokadi, or and the team, we can report on these indicators. There will be indicators that we will require that they be reported on a daily basis, and those will be the indicators that immediately tells us of the performance. And there will be indicators that will be of weekly basis. So those will also be made more, we'll clarify that as we are in a position to start collecting the reports from the districts. And in terms of the suggested addition for the indicator, that is very much welcome. He's quite right that it is also important that we know the characteristics of the patients that are at home, so that we are able to know as to the inherent risk that is within that community. Thank you.
Thank you so much, Doc. Thank you so much to everyone who asked. And any other questions or comments? Okay. No, I would like to appreciate everyone who joined the webinar today. Please do join us every Thursday as we discuss these issues. Dr. Mukadi, you have your hand up.
No, it's a mistake. I'm trying to lower it. So it's all the hand up.
Oh, okay. That's fine. Okay, I was saying thank you everyone for joining, and please do join us next week as well. Dr. Gaolathe, please do say a few closing remarks for us.
Dr. Gaolathe has sent her apologies. She's not with us this afternoon, but next week we will have DHMT reports from Okavango DHMT and Maun. So please do join us for those. And I've put my number on the screen for you and your colleagues to call me. And if you have a desire to be included in our lineup, that's where you can reach me. Or if you want to be added to the mailing list as well, my email address was given earlier, and that is the number where to reach me, either by phone call or by WhatsApp. Thank you very much. Have a good evening and see you next week.
Thank you, everyone. Have a good evening.